Hi, I'm Gladysel.
I'm Kimberlyn.
And I was behind the camera. So today our case study is going to be over our patient, Ricky Ricardo Richards. He's a 35-year-old male. He's a full-time banker, part-time golfer. He suffered a labral tear in his right shoulder. Method of injury is somewhat unknown. He does know that he was feeling some discomfort for some time in his shoulder. He did realize the pain when he went out with a couple of coworkers to go celebrate a promotion. A description of the anatomy. So the shoulder itself is made up of 3 bones, which is the clavicle, the scapula, and the humerus. So the scapula contains the glenoid fossa, which is going to have that labrum. The labrum, its purpose is to deepen the socket and make it more stable for the humerus, since it's so small. Over time, the soft labral tissue may get caught between the glenoid and the humerus, and it might make it tear. So if the tearing is successful, then it can catch with different shoulder movements, causing pain and instability. So a couple of concerns and precautions. So some concerns are that we want to limit any excessive range of motion, and then the level of pain also. We want to keep his pain at a minimum so that way he's still able to do his ADLs. Some precautions, so no lifting, no overhead reaching, no reaching behind the back or head. We want to keep it as safe as the situation as possible. We don't want him to further irritate the problem or even cause himself like secondary injury because of his shoulder pain.
We decided to go through with the operative procedure for our patient, and the patient would be in a sling for 4 to 6 weeks. So from day 1 to week 2, our goal would be the patient will perform isometric contractions by squeezing a stress ball for 30 seconds 3 times by April 4th. And some exercises that would help him achieve this goal would be just wrist and hand range of motion exercises and hand gripping strength exercises.
Our patient is in the sling. We would have them performing simple hand and wrist range of motions, which means they would be doing flexion, extension, and deviations. In addition, with the stress ball, they'd work on their isometric grip by holding, squeezing, progressing to holding for a longer contraction, and releasing with a shorter rest time.
In the next progression from week 3 to week 6, the patient would come out of their sling at week 4, but our goal for this time period, the patient will be able to place cans on different levels of the shelf while counting backwards from 100 by April 20th, 2017. We would continue wrist and hand range of motion with added hand weights, and then we would still do hand gripping exercises to increase strength. But once he comes out of his sling at week 4, we would begin range of motion exercises for the shoulder, and we would perform finger ladder exercises with him just going up and down, out and across on the finger ladder. And then we would also have him trace a star pattern on the wall to increase his range of motion, and we could also have him perform that with his eyes open and his eyes closed.
So for phase 2, during week 3 to week 6, we would include the range of motion exercises that we were already doing, but with added weight. In addition, we would progress to work on shoulder range of motion and doing hand ladders, going up, and then also progressing to going side to side and diagonals. Is having them trace the star to actually do the movement through the shoulder.
Except from week 12 post-op, our goal would be to have the patient be able to go through the D1, D2 upper extremity patterns while resisting the clinician, closing force for about 6 to 10 seconds at the end range 10 times by May 15th, 2017. Some exercises that would help him achieve this goal would be the I's, Y's, and T's. We would start him without weights and then increase his weights as he went. Holding a stick, he would use his good arm to move the operated arm through the range of motion for a good stretching and increasing his range of motion. Do some rhythmic initiation in the D1 and D2 exercise patterns to increase his strength, and then just continue to build his strength up with elbow flexion and internal external rotation 0 degrees abduction.
For this exercise, the patient's going to use a stick. They're going to use their good arm to push the operated arm into the motion that they want. So right here we're doing AB and adduction. And then same for flexion and extension, the patient's going to use their good arm to push the operated arm into the motion that they want. Okay, so the patient's going to perform I's, Y's, and T's. This is going to be during the 7 through 12 week time period. This is going to be maintaining the range of motion and also increasing strength in the shoulder. So the patient will demonstrate an I, Y, and T.
The next phases of his rehab program would be week 13 through 20, and our goal for that time period we would have the patient would be able to perform good golf technique 7 times out of 10 without pain by May 30th, 2017. We would instruct the patient to perform body blade exercises and TheraBand pull-aparts. We would instruct him on the body blade to go through the D1, D2 patterns, because those are like the main patterns for a golf swing. And then on the TheraBand pull-aparts, just make sure he's squeezing his scap and like keeping his scapula like contracted while he's pulling apart the TheraBands. Next, we're going to have the patient perform D1, D2 motions with the body blade. So for D1, we would just start here, go up and down, and then D2. And then we're going to have our patient do TheraBand pull-aparts, and we're going to make sure they're against the wall so their scapulas are retracted and their elbows are in close to their body, and we're just going to have them do TheraBand pull-aparts, like so. Week 21 through 24 would be our next phase of rehab, and it's the end phase of rehab. So our goal for that time period we would want the patient to be able to successfully hit 5 golf balls onto the green from 100 feet away by June 16th, 2017, or June 19th by 2017. Some exercises he would be able to perform would be Russian twist, just because we would also want to strengthen up that core, because a golf swing he's going to need a strong, stable core. And we would also continue the D1, D2 patterns, but on the cable machine, because he's able to increase his weight a lot. We also have him use a weighted golf club and go through the actual swinging motion, just so he's able to feel that swinging motion before he returns fully to try to achieve his goal.
Next exercise that we're going to do is a Russian twist. So we're going to get a medicine ball, and the patient is going to sit like this, and they're just going to move side to side to get the trunk rotation that they're going to need when swinging the club.
Since we didn't have a cable machine, we're going to act as Gladysel, being our cable machine. And so we would take our patient through D1, D2 flexion and extension motions. So right now we're going to be in D1 extension, and we would tell the patient to go through D1 extension motions, and then we would turn, and this would be D2 extension on the cable machine. And then on our cable machine, we would adjust it so it would come down low. The main differences between an operative and non-operative rehab for labral tear: the operative is going to focus on mainly isometrics first, because the patient's going to be in that sling for 4 weeks, and so just mainly just sitting there, gaining strength back in his arm by doing isometrics and range of motion stuff with his wrist. And then the non-operative side, you actually want to gain your range of motion back first as quickly as possible, just so the joint doesn't become together and frozen. And those are the 2 main differences between operative and non-operative. But overall, both rehab programs focus on return to play as soon and safely as possible with the same amount of strength and range of motion as before the injury occurred. And these are our citations.